Today's SGT talk is on pancreatic diseases, and I shall be basically talking on the surgical conditions affecting the pancreas. Okay, the outline of the talk today is on the important aspects of the pancreas you are expected to know. Okay, first, the anatomy and physiology, the applied anatomy and physiology, and the common surgical diseases of the pancreas, which are 4 of them is listed here. You're also expected to be familiar with some congenital anomalies, ectopic pancreas, cystic fibrosis, annular pancreas, and congenital cystic disease. After which, we shall then go through some questions on the subject. Okay, this slide shows the picture of a diagram of a pancreas. Okay, this yellow structure here is the pancreas, which consists of a head, body, and tail. Okay, as you all know, the pancreas is a retroperitoneal organ where the head nicely sits into the C shape of the second part of the duodenum. Okay, there are two types of cells in the pancreas, the exocrine and the endocrine. The exocrine glands occupy 80% of the cells, and these are the acinar cells which secrete the digestive juice into these glands. These digestive juices contains amylase, trypsin, and lipase. Together, they are known as the digestive enzymes. And these are carried into the main pancreatic duct, which runs through the body throughout the length of the pancreas, and it enters into the second part of the duodenum as the ampulla of Vater after being joined by the CBD. Therefore, the digestive enzymes are secreted into the second part of the duodenum. The other gland is known as the islet glands of the pancreatic islets, which constitute about 20% of the cells. Okay, the islets of Langerhans, which consists of two types of cells, the alpha cells which produce glucagon, and the beta cells produce insulin. These two come under the endocrine glands, as the endocrine glands which produce pancreatic hormones insulin and glucagon. The pancreas is closely associated with the second part of the duodenum, the splenic artery and vein, and the lower part of the hilum of the spleen. These are important when operations on the pancreas are contemplated. As I said, the pancreas consists of exocrine portion, which is the predominant component, and an endocrine portion, which contributes less than 1/4 of the gland. The exocrine portion is responsible for secreting serum amylase, the most widely used blood test for pancreatic damage, serum lipase, and serum trypsin. Lipase for the digestion of fats, and trypsin for the digestion of protein. Other enzymes include elastase and chymotrypsin. The endocrine portion, which consists of clusters of islets of Langerhans or pancreatic islets, consists of three types of cells: A cells, alpha cells, which secrete glucagon; B cells or the beta cells secrete insulin; and the D or delta cells secrete somatostatin. The most predominant component is the B cells or the beta cells which secrete insulin, which reduces the blood sugar. Glucagon increases the blood sugar. Okay, now the exocrine function being the most predominant function of the pancreas, what stimulates its secretion? Okay, what stimulates the pancreatic secretion of these enzymes? Basically, the stimulus comes from two main sources. One is the presence of food in the duodenum, which prompts or stimulates the duodenal mucosal cells to secrete secretin and cholecystokinin, which have a positive influence on the pancreatic secretions. The second stimulus is the vagus nerve, which increases the volume of these secretions from the pancreas.
Now, for pancreatic diseases, certain investigations are commonly done, which include the list I listed here. Blood tests, especially serum amylase and lipase. Sometimes certain immunoglobulins can be done for immune diseases, immunostimulatory diseases. Urine tests, amylase, trypsinogen 2, and diastase also increase in patients with pancreatic damage. Stool tests, fecal tests, and stool elastase tests are also important to assess the function of the pancreas. Ultrasound abdomen to detect mass lesions, dilated ducts, and pancreatic calcifications. CT scan is a very important diagnostic modality for detecting enlargement of the pancreas, tumors, and acute necrosis. MRCP is another important diagnostic tool, especially it gives a very good imaging of the pancreatic and bile ducts. Endoscopic ultrasound or EUS for close-up view of the lower end of the pancreas, the head of the pancreas and the pancreatic ducts, and even doing endoscopic biopsies of this region. The last one I mentioned here is the pancreatic function test or PFT, which is also known as the secretin stimulation test. Okay.
Next, we come to pancreatitis. As the name suggests, it is inflammation of the pancreas. Okay, there are two types of pancreatitis, acute and chronic. Acute pancreatitis, there are again two types, mild and severe. In mild pancreatitis, there is interstitial edema and mild dysfunction of the pancreas. It involves 80% of cases and the mortality is around 1%. And most of these patients undergo full recovery after the first week. In severe pancreatitis, apart from inflammation, there is also necrosis of the pancreas. About 20% of cases belong to this severe form, and this mortality can rise as high as 20 to 50%. And these are usually due to multi-organ failure in the first week and septic complications after the second week. In chronic pancreatitis, there is continuing and persistent inflammatory disease or repeated attacks of acute inflammation. And this leads to irreversible morphological changes and leading to pancreatic failure, either partial or total. And the clinical features of this condition will be chronic and persistent chronic pain and persistent loss of pancreatic function, leading to malabsorption and steatorrhea. Next, we come to etiology of acute pancreatitis. The two most common causes are biliary stones, which account for nearly 70% of cases, and alcoholism for about 20% of cases. Other important causes include trauma, blunt abdominal injury, and surgical trauma such as post-ERCP. Tumors like ampullary tumors, drugs including steroids, azathioprine and thiazides, hypercalcemia due to hyperparathyroidism, and hyperlipidemia. Other less common causes are viral infections such as mumps in childhood, and the other virus is Coxsackie B, scorpion bites, malnutrition, annular pancreas, autoimmune diseases, and hereditary and idiopathic conditions. Okay. Coming to pathogenesis of acute pancreatitis, there are three main enzymes within the pancreas that is involved. Okay, first is trypsin and chymotrypsin, which digest proteins, amylase, which digests carbohydrates, and lipase, which breaks down fats. In acute pancreatitis, what happens? There is an abnormal activation of these digestive enzymes within the pancreas. And this is caused by the inappropriate activation of inactive enzyme precursors called zymogens or proenzymes. Okay, and these proenzymes within this pancreas are activated, and notably the most important of being the trypsinogen. Okay, the pathway, we have your noxious stimuli which activate the trypsinogen. Okay, and this trypsinogen activates the trypsin becomes active, and this trypsin results in auto-digestion of the pancreatic cells.
The most common cause, as I said, is gallstone, which is the cause of acute pancreatitis. This diagram shows you the setup of the biliary tree at the lower end of the biliary tree. The bile duct, common bile duct, and the pancreatic duct join to form the ampulla of water, and that empties into the duodenum. Okay, this is a close-up here, ampulla of water. A stone that passes through this ampulla of water causes a transient blockage of the pancreatic duct, and that triggers an acute inflammatory process.
Okay, this slide shows you the pathogenesis of acute pancreatitis. Okay, the main cause or the underlying cause of acute pancreatitis is injury to the acinar cell of the pancreas. Okay, so there are three main causes of this injury to this acinar cell. First, most common is duct obstruction. Second, direct acinar cell injury. And third, defective intracellular transport within the acinar cell. Okay, in the first one, with duct obstruction, the common causes will be gallstone disease, which causes blockage of the pancreatic duct, chronic alcoholism, and tumors of the pancreas. Okay, this blockage leads to interstitial edema with impaired blood flow and ischemia of these pancreatic tissue, leading to acinar cell injury. The second group is direct injury to the acinar cell, and these include alcohol, drugs, virus, trauma, and ischemia. Okay, generalized ischemia, which releases the intracellular proenzymes in the acinar cells, and activation of these proenzymes to the active enzyme, which again causes injury to other acinar cells within the pancreas. The third group of conditions where there's defective intracellular transport in the acinar cells. And this is due to metabolic injuries from various diseases, alcohol, and duct obstruction. This results in delivery of the proenzymes to the lysozyme with activations of these enzymes, leading to further to this acinar cell injury. Okay, once there is acinar cell injury from various causes mentioned above, then the enzymes are activated, the pancreatic enzymes are activated. And once these pancreatic enzymes are activated, then there is interstitial inflammation and edema in the pancreas, proteolysis due to release of proteases, fat necrosis due to lipase and phospholipase release, and massive hemorrhage within the pancreas, the so-called hemorrhagic pancreatitis. So these are the various mechanisms that lead to acute pancreatitis.
Next, we come to the clinical presentation of acute pancreatitis. First, the symptoms. The most predominant or the most prominent symptom of acute pancreatitis is upper abdominal pain. The pain is usually in the upper abdomen, epigastric region, lower epigastric region, around the umbilicus, more to the left. The pain usually radiates to the back. Okay, that means from front to back. Relief by bending forwards or lying in a curled up position. And the abdominal pain feels worse after eating. It's precipitated by food or aggravated by food. and there is significant degree of nausea and vomiting, and even retching. So vomiting is a very prominent symptom in these patients. So the pain and vomiting are very important abdominal symptoms. Next, the signs can be due to the inflammation. There can be fever, usually tachycardia, dyspnea, jaundice, tenderness, gray turners and colour sign, silent abdomen. Silent abdomen, that means on auscultation there are hardly any bowel sounds, and there's also leukocytosis. This tenderness and sometimes there's guarding is maximum around the area of the umbilicus and epigastric region. This is a picture showing you the classical picture of a pain in severe acute pancreatitis. So I said the onset is acute, site epigastric or upper abdomen, mostly on the left side. Character is agonizing, very severe pain, agonizing pain, burning, continuous, and most of the time it does not relieve with normal medication. Some people describe it as excruciating pain. Radiation towards the back, chest and lower abdomen sometimes may mimic an aortic aneurysm rupture or a myocardial infarction. An aggravating factor by lying supine position, patient unable to lie in the supine position or refuses to lie down to be examined. And relieving factors sitting up and leaning forward as shown in this picture. Okay, leaning forward to relieve and applying pressure to his upper abdomen to relieve the pain a bit.
Okay, the main feature of acute pancreatitis is severe abdominal pain. And this pain is usually in the epigastric region and left upper quadrant. The pain is severe, and this pain is relieved by lying in a lateral position, bent up lateral position. And here another picture to show you the curled up posture of the patient to relieve the pain. The pain is usually severe, sudden onset, epigastric region, radiates to the back, and it is relieved by bending forward and associated with profuse vomiting.
Okay, this slide shows you the abdominal wall bruising that can occur in acute pancreatitis. Okay, here you have got bruising around the umbilicus and the anterior abdominal wall, and this is known as Cullen sign. And here there is bruising in the lateral abdominal and abdominal wall, and this is known as the gray turner sign. Okay, Cullen sign, periumbilical bruising of the anterior abdominal wall, and bruising in the lateral abdominal wall. Here, extensive bruising extending from the lateral abdominal wall, pelvis, and the upper thigh.
Now, what are the differential diagnoses of acute pancreatitis? So, it's a patient, it's a usually a patient, young patients with severe abdominal pain, acute onset, vomiting, and signs of peritonitis. So, these are the common differential diagnoses for this condition: perforated peptic ulcer, acute cholecystitis, ascending cholangitis, acute appendicitis with perforation, acute intestinal obstruction, acute mesenteric ischemia with gangrene, acute myocardial infarction, and abdominal aortic aneurysm rupture or leaking. Okay, so these are all causes of acute abdomen.
An important method in the treatment of pancreatitis is to assess the severity of acute pancreatitis. And this can be done by using a number of methods, among which the most established and the oldest form is called Ranson score. Okay, there are 11 parameters that are looked in. First, on admission, there are 5 of them. age of the patient more than 55 years of age, white cell count more than 16,000, blood glucose more than 11 millimoles per liter, provided the patient is not diabetic, LDH or lactate dehydrogenase more than 350 international units per liter, and the amino AST and ALT more than 250 units per liter. Okay, and the other thing that you must do is to assess the patient within the next 48 hours of the onset of the acute pancreatitis. Fall of hematocrit more than 10%, blood urea nitrogen increases more than 5 milligrams per deciliter, PaO2 less than 60 millimeters mercury, serum calcium less than 2 millimoles per liter, base deficit more than 4 millimoles per liter, and fluid sequestration estimated more than 6 liters of sequestration. Okay, each of these items carry a point. Therefore, on admission, it's 5 points, and within 48 hours is 6 points. Together, 11 points. The severity of the condition can be due to the score according to the ransom score. Okay, the ransom score helps to predict the severity and outcome of acute pancreatitis at 48 hours after onset of illness. It can be mild or severe pancreatitis. Mild pancreatitis when there are less than 3 factors positive. And in these cases, the mortality rate is much lower, much less than 5%. In severe pancreatitis, the factors ransom score is more than 3 positive. If it is 3 to 4, the mortality rate is 15 to 20%. And this risk increases to 40% with the risk of 5 to 6 factors. If the factors positive is more than 7, then 99% mortality. Okay, so in summary, a score of 3 or greater predicts severe acute pancreatitis and possibly higher mortality. The next method that is used is the modified Glasgow-Emery score or modified Glasgow score, which again assesses the patient on admission and within 48 hours. But the number of factors have been reduced to make it simpler. Here, we take the age into consideration, total white cell count, blood glucose, blood urea, and PaO2. Okay, these are the 5 factors you take on admission, and each of them, if exceeds the value as indicated, is scored 1 point. And the patient is assessed over the next 48 hours with serum calcium, albumin, LDH, and the liver enzymes. Okay, and again 1 point each for any of these which are positive. So it can be a minimum score of 0 and a maximum score of 8. A score of less than 3 is severe pancreatitis is unlikely. If a score is 3 or more, severe pancreatitis is likely. Okay, next we come to imaging methods used in acute pancreatitis. First, plain X-ray and chest abdomen and abdominal X-ray, where it shows localized ileus, the sentinel loop, colon cutoff sign, renal halo sign, which are all classical signs of acute pancreatitis. Also, it can show radio-opaque gallstones, free gas under diaphragm to rule off pneumoperitoneum, and pleural effusion to rule out diffuse interstitial inflammation of the lung. Next is ultrasound scan of the abdomen, is mainly to detect gallstones and enlarged pancreas. Contrast enhanced CT scan for severe cases, especially with necrosis and abscess formation. MRI scan is rule out bile duct pathology, especially for strictures and stones. And EUS gives you a closer image of the CBD and the pancreatic duct, and biopsy can be done to confirm or exclude malignancy.
Okay, this slide shows some images of acute pancreatitis. Okay, this is a plain X-ray of the abdomen, shows you a loop of transverse colon, which is clearly seen, and there's a sudden cutoff of the air from the colon, splenic flexure into the descending colon. There's no air in the descending colon, and this is known as the cutoff sign, which is due to localized ileus of the transverse colon due to acute inflammation of the pancreas. And this is the erect chest X-ray, shows you air, free air under the right diaphragm. Okay, this is above the liver and below the diaphragm. This is known as pneumoperitoneum. This is a diagnosis of perforated peptic ulcer, which is a differential diagnosis of acute pancreatitis. And this is a CT scan showing you an enlarged, very grossly enlarged pancreas, which are features of acute pancreatitis that is swollen and enlarged. Here, another X-ray or CT scan showing you these are the kidneys. There's a hypodense area over around the kidney, and this is known as the bilateral renal halo sign. So these are all typical features seen in patients with acute pancreatitis.
This is abdominal ultrasound. Okay, abdominal ultrasound of this thing, and this shows you the enlarged pancreas here. Okay, enlarged pancreas, and in the middle runs the pancreatic duct, which is also dilated. Okay, the red arrow shows here. Here again, a huge pancreas. Okay, this is a huge pancreas. It's dilated, and there's some fluid there. Okay, so these are the different CT scans of a normal pancreas. Okay, normally you can see here, this is a normal pancreas, tail, body, and the head here. This is acute pancreatitis, gallbladder pancreas diffusely swollen. Okay, and this is a pseudosis that is found in an inflamed pancreas. Acute pancreatitis complicating the pseudosis. This is a EUS, endoscopic ultrasound, which clearly shows a stone in the lower end of the CBD or ampulla of water, which is clearly causing obstruction of the pancreatic ducts. Another one, stone in the CBD.
So in summary, the diagnosis of acute pancreatitis is based on typical abdominal pain, the serum lipase or amylase activity more than 3 times the upper limit of normal, and thirdly, the characteristic CT findings. Next, we come to the complications of acute pancreatitis. There are two broad groups. One is systemic complications due to severe pancreatitis, which occurs during the first week of the illness, and local complications, which are usually due to milder pancreatitis, and these occur after the first week of the illness. Under the systemic illness, you have cardiovascular problems, hypovolemic shock and arrhythmias, pulmonary atelectasis and pleural effusion and pneumonia. Sometimes ARDS can also complicate. Renal problems, acute renal failure, hematological problems like disseminated intravascular coagulopathy or DIC, metabolic problems, hypocalcemia, hypolipidemia, gastrointestinal paralytic ileus and GI bleeding from stress gastritis, and neurological problem where patient develops visual disturbances, confusion, irritability, and cephalopathy in severe forms. The local complications include acute fluid collection, which may require percutaneous aspiration if the collection is large, pseudosis of the pancreas, pancreatic necrosis, pancreatic abscess, pancreatic ascites, hemorrhage into the gut, and portal vein thrombosis, or even splenic vein thrombosis.
Okay, massive necrosis, and here necrosis secondarily infected bacteria and forms a pancreatic abscess. Here, this is a pseudosis when the collection later becomes well encysted, and that's known as a pseudosis. Here is a pseudosis when the wall of the cyst is formed by the surrounding tissues. That is called a pseudosis.
Treatment of acute pancreatitis. First, we have the general resuscitation or initial supportive treatment. Then you have followed by the definitive treatment, either surgical or medical, and then treatment for complications. Under the general treatment, resuscitation, and initial supportive treatment, you have replacement of fluids. Adequate early fluid resuscitation, especially within the first 24 hours, is very, very important. Some patients may need nutritional support, can be either enteral or parenteral, and nowadays it's always advisable to give early parenteral feeding through the nasogastric tube. Pain control is another important factor. Morphine, pethidine, or other opiates may be necessary. Treatment of underlying issues such as acute respiratory failure, multi-organ function, and gallstone. Use of drugs, somatostatin, octreotide, PPI, and antibiotics. And it is very important that these patients must be monitored closely in HDU or ICU. Okay, the next group of treatment is for the definitive treatment, which involves ERCP and early sphincterotomy if gallstones are detected in the CVD. And this is then followed by laparoscopic cholecystectomy. ERCP must be done early as possible to remove the stone, and laparoscopy cholecystectomy usually done before the patient is discharged. For complications of acute pancreatitis, you have surgical procedures such as drainage or pseudosis, which consists of cyst gastrostomy, which can be laparoscopic or endoscopic, excision of the necrotic tissue or necrosectomy, and if there is abscess, drainage of abscess. These surgical procedures can be done either endoscopically, laparoscopically, or open surgery. Okay. One of the complications of acute pancreatitis is pseudosis, the pancreatic pseudosis, which is a collection of amylase-rich fluid enclosed in a wall of fibrous or granulation tissue. So it's a pseudosis. It's a false capsule or false wall. It occurs 4 weeks or more after an acute attack of pancreatitis. It can also occur after chronic pancreatitis or after a pancreatic trauma. The clinical presentation is usually patient has got a history of pancreatitis, acute pancreatitis, regardless of its cause, and the onset starts after the second week onwards, and the commonest presentation is a slowly or increasing epigastric mass. The size increases, with the mass is non-mobile and non-tender, and if it is large enough, they can present with obstructive symptoms, especially jaundice or gastric outlet obstruction. The diagnosis is quite simple. It's confirmed using an ultrasound scan or a CT scan. Okay, this is an ultrasound picture showing you a cyst around the pancreas. And here, a CT scan, which is shows more clearly a pseudosis of the pancreas. So we come to the complications and surgical treatment of pseudosis. Okay, the complications include infection leading to abscess formation and septicemia, rupture into the gut, leading to GIT bleeding, internal fistula, and peritonitis. The cyst, when large, can cause compression of the biliary tree with obstructive jaundice, or bowel obstruction due to external compression by large cysts. and sudden pain from hemorrhage into the pseudosis. Patient can suddenly bleed into the pseudosis, causing severe pain and shock. Now, the surgical treatment for pseudosis of pancreas is basically surgical, and this is known as cisgastrostomy, where you create the fistula between the cyst and the posterior wall of the stomach, thereby draining the fluid from the cyst into the stomach. This can be done either percutaneously, known as the transgastric cisgastrostomy, which is a temporary measure. It can be done endoscopically through the stomach, through the OGDS, and it can also be done open cisgastrostomy with a running stitch along the edges of the opening, suturing the posterior wall to the capsule of the pseudosis. Okay. This picture shows you an open cisgastrostomy. Okay, now this is the stomach and this is a cyst in the pancreas here. So you go in, open the stomach and create a fistula between the posterior wall of the stomach and the cyst. And this is known as cisgastrostomy. By doing so, the contents of the cyst are drained into the stomach, and from where it can be either aspirated upwards through the nasogastric tube, or most of it goes down into the intestine. Okay, this is the opening in the posterior wall where there's a running continuous sutures placed between the posterior wall and the mature pseudosis wall. Okay, thereby creating a large fistula. Other methods which I said can be endoscopic cisgastrostomy or laparoscopic cystogastrostomy. Okay, now we come to the next disease known as chronic pancreatitis. Now, as the name suggests, it's chronic inflammation of the pancreas. Okay, and it's usually due to recurrent attacks of acute pancreatitis and is associated with severe pain, exocrine and endocrine insufficiency, and males are more affected than females, 4:1, and it usually affects adults above 40 years of age. Among the causes, the two main ones are chronic alcoholism, which accounts for 60 to 70% of cases, and pancreatic duct obstruction. Okay, and the most common cause will be gallstone and strictures of the bile ducts. Other causes include hereditary pancreatitis, autoimmune pancreatitis, and idiopathic causes. Less important are carcinoma of the pancreas, pancreas divisum and annular pancreas, which are congenital conditions, cystic fibrosis, malnutrition, hyperlipidemia, and hypercalcemia, usually due to hyperparathyroidism. Okay, next we come to the clinical presentation of chronic pancreatitis. Okay, as I mentioned, pain is the most important and prominent symptom of chronic pancreatitis. The pain is persistent, chronic, and intractable. Okay, because of this, the patients become addicted to analgesia, especially narcotic analgesia, on which the patient becomes dependent. The pain is recurrent attacks of severe pain, which is dull, gnawing, and epigastric region and subcostal region. Pain may radiate to the back or to the left shoulder. Other symptoms include nausea, vomiting, weight loss, and inability to work. Okay, most of these patients lose their job and becomes unemployed. Malabsorption and steatorrhea, diabetes mellitus, and the important thing about this disease is a chronic debilitating illness which is progressive. Okay, here is a patient with chronic pancreatitis with chronic upper abdominal pain, loss of weight, and the patient looks very miserable. Now, what are the pathological changes that take place in the pancreas in chronic pancreatitis? The gland becomes enlarged, hard, and fibrotic. There are multiple strictures of the pancreatic ducts with dilatation and stricture of ducts with calcified stones within, which are clearly seen on X-rays. And these pancreatic ducts and ductules becomes occluded, and sometimes they have multiple inflammatory cysts are noted. Okay, the investigations for chronic pancreatitis, again, blood investigations, serum amylase, this may be elevated only in the early stages. With progressive chronic inflammation, the amylase levels may become normal or reduce. Next is plain X-ray abdomen. You will see pancreatic calcification. It's shown in this X-ray here. See, there's a multiple calcification of the pancreas here. So, okay, with clinical symptoms and a pancreatic calcification or X-rays are almost sure of diagnosis of chronic pancreatitis. In CT scan, will show dilated ducts with calcification. Okay, here you see dilated ducts with calcification in the pancreas. Now, if you do a ERCP for these patients, it will show multiple strictures and circulations. 6 strictures with dilatation. They look like they are described as chains of legs. Chain of legs here. Okay, this is a chain of legs or beaded. Multiple dilated ducts intertwined with strictures. So these are known as chain of legs or a beaded appearance. ERCP is important, especially if you're deciding to do surgery.
Treatment for chronic pancreatitis, mostly medical. Control of pain, very important. I say patient become addicted to analgesics. Improve digestion, giving supplements, because the pancreas is not able to produce enough of enzymes to digest. So these enzymes, a lot of enzyme preparations are available, which patient has to take before meals. And also control of diabetes. Interventional treatment is to relieve obstruction of the pancreatic duct. If all means of relieving pain fails, then you may have to resort to relieve the obstruction of the pancreatic duct. Then you must need to treat the complications such as pseudosis or abscesses that may develop, fistula, ascites, varices. And this relief of obstruction can be done through endoscopic procedures, ERCP, by doing a sphincterotomy and placement of stents across the strictures in the pancreatic duct, drainage of pseudoducts through pseudosis through ERCP, and lastly surgery to remove any mass lesion that may cause obstruction, to remove such obstruction.
Coming to carcinoma of the pancreas, are two major types. Exocrine cells, which occupy more than 90% of the tumors, and from neuroendocrine, less than 10%. Okay, the large percentage of exocrine tumors which arises from the acina cells are the malignant ductal carcinomas, okay, which account for about 85% of all exocrine functions tumors. And these ductal adenocarcinomas mainly arise in the head of the pancreas. They are solid, fibrous, and with dense fibrosis, difficult to differentiate from chronic pancreatitis, at times needing biopsy. And they tend to infiltrate locally along the nerve sheath via the lymphatics and blood vessels. They usually originate in very tiny lesions known as the pancreatic intraepithelial neoplasia, which is equivalent to the pancreatic carcinoma in situ. Liver and peritoneal metastases by these tumors are common. The other less important or rare tumors, malignant tumors, include the serous or mucinous cyst adenocarcinoma and the intraductal mucinous papillary tumor. Among the benign tumors, The important ones are the adenomas, the serous and the mucinous cystadenomas, of which the mucinous cystadenomas may have malignant potential. There are also the neuroendocrine tumors which arise from the neuroendocrine cells, which are very rare, very much less than 10%, and some of them include the insulinomas, glucagonoma, somatostatinoma, and VIPoma.
What are the risk factors for carcinoma of the pancreas? Age is a very important factor, usually occurs in elderly people above 65 years of age. Males are more common. Cigarette or tobacco smoking is a predisposing factor. Family history, higher family history in such cases. Hereditary pancreatitis, chronic pancreatitis also in the long term predisposes to cancer of the pancreas. Hereditary non-polyposis colorectal cancer, ataxic telangiectasia, Peutz-Jeghers syndrome, familial adenomatous polyp, and diabetes mellitus. Okay, these are some of the risk factors for the development of pancreatic cancer.
Now, what are the clinical presentations of carcinoma of the pancreas? Okay, the clinical picture depends on the site of the tumor. Okay, it can be one when the tumor involves the ampulla or the pancreatic head, or the second group is when the tumor involves the carcinoma of the body or tail of the pancreas. In the first group, the ampullary or the pancreatic head carcinoma, the patients present with painless obstructive jaundice, progressively painless obstructive jaundice, pruritus, dark urine, pale stools, malabsorption and steatorrhea, nausea, epigastric pain or discomfort, and definite evidence of loss of weight, hepatomegaly, and a palpable gallbladder. Okay, so here it tells you this is the pancreatic head tumor here. Okay, this tumor causes obstruction of the lower end of the bile duct, causing all these features. Okay, the enlarged gallbladder is the basis of the Covius law that we get in patients with such lesions. The second group of tumors will be the carcinoma of the body and tail. Patient has got vague discomfort, anorexia, weight loss, chronic back pain, epigastric discomfort with recent onset of diabetes in patients above 40 years of age, unexplained pancreatitis or unexplained acute pancreatitis, advanced cases with enlarged Virchow's node and ascites, abdominal and pelvic metastasis. Another important feature is any unexplained weight loss. You must consider carcinoma of the body and tail of the pancreas. Okay, what are the investigations for carcinoma of the pancreas? Okay, blood tests, especially if the patient has obstructive jaundice, urine and blood tests, liver function test, looking for confirmation of the obstructive jaundice, the prothrombin time, which may be prolonged in obstructive jaundice patients, and very important is to do a CA19-9, okay, which may be elevated in carcinoma of pancreas. Next, we come to ultrasound scan of the abdomen, mainly to look for dilated biliary tree, gallstones, and mass lesion in the pancreas. Next, come to contrast enhanced CT scan of the abdomen, which is one of the best methods of imaging for carcinoma of the pancreas. It is also helpful in staging and determining the resectability of the tumor. Next, you have the ERCP or the endoscopic retrograde cholangiopancreaticogram, which gives you determine the status of the biliary ducts, as well as use brush cytology or biopsy in cases of ampullary tumors. And lastly, you have the endoscopic ultrasound, which is transduodenal or transgastric ultrasound with FNAC. Okay, under this ultrasound guidance, okay, where you have a closer look of the head of the pancreas, and biopsies can be taken through this method.
Next we come to the pancreatic cancer staging. Pancreatic cancer, the T staging. T staging, TNM staging. The T staging is T1 and 2 limited to within the pancreas. Okay, within the tissues of the pancreas. T1, tumor size less than 2 centimeters, and T2 more than 2 centimeters. T3, when the tumor infiltrates into the duodenum or infiltrates into the spleen. Okay. Infiltration into the kidney is also considered as T3, the hilum or part of the kidney, and infiltration into the splenic vein also considered as T3. So T3 is local adjacent infiltration of the tumor into the adjacent organs, the spleen, duodenum, kidney, and the splenic vein.
Okay, now let's look at the resectability criteria for carcinoma of the pancreas. Okay, there are 4 stages. Stage 1 is obviously resectable. Okay, T1, T2, N0, M0. Okay, so this is definitely resectable. And T4 is definitely unresectable. Any T, any N, and there's already M1. Okay, and the common metastasis sites are liver, peritoneum, and lung. So once these are involved, then is stage 4 unresectable. Now, stage 2 and stage 3 are the in-between. Stage 2 is typically resectable, is T1, T2, or T3 with N1, but there's no metastasis. Okay, and the other important criteria in this patient is the involvement of the status of the cilia and axis or the SMA artery. In these cases, there's no encasement of these arteries, so it's considered resectable. Whereas in stage 3, it is unresectable because it may be T4, N0 or N1, but there's no metastasis. However, in these patients, there may be regional lymph nodes, but the SMA and cilia axis are not encased. There's no encasement of the cilia axis and the SMA. So this becomes resectable. Okay, so the important factor for marginal cases is the involvement in an encasement of the cilia axis and SMA. If they are encased, unresectable. If they are not encased, then resectable. Next, we come to the management of pancreatic cancer. For the purpose of this table here summarizes the management of pancreatic cancer. Once a diagnosis is made, it's classified into resectable, borderline, or advanced. Resectable, the decision is straightforward. Total curative surgery followed by adjuvant chemotherapy. In borderline cases, there's borderline resection, neoadjuvant therapy, chemotherapy or chemoradiotherapy, okay, to downgrade the tumor if possible. If it is suitable, then you proceed after that with surgery. If it is not, then proceed with palliative chemotherapy. For advanced pancreatic cancers, it can be locally advanced or metastatic. For locally advanced, if the prognosis is good, clinical trial of palliative chemotherapy is given. If it metastatic advanced cancer, treatment is purely palliative chemotherapy. And the drugs used are gemcitabine, 5-fluorouracil, oxaliplatin, and fulvestrant. FOLFIRINOX. Okay. This last slide summarizes the surgery for carcinoma of the pancreas. There are two groups of patients. Resectable, 15% of the patients, the tumor is resectable. So in these cases, you have got two main situations. One is carcinoma head of the pancreas, where a pylorus preserving pancreatoduodenectomy or PPPD with local lymphadenectomy is the treatment of choice. The more widely used, more established treatment is Whipple's operation, where you remove the gastric antrum together with the bile duct and pancreas. The second group of conditions, which are fewer patients coming into this condition, is when the CA is involving the body or tail of the pancreas. So in these patients, the operation that is preferred is distal pancreatectomy. In the majority of cases, 85% of cases, at diagnosis on admission is unresectable. The tumor is unresectable. So in these patients, there are two operative procedures that can be done. First is when the patient is developed jaundice due to CBD obstruction by the tumor. So you can do a ERCP stenting or bypass procedures. The three common ones are choledochoduodenostomy, choledochojejunectomy, and cholecystojejunectomy. The second group of patients, less rarer condition, is when the patient comes with duodenal obstruction by invasion of the tumor into the second part of the duodenum. And these causes can be relieved with endoscopic stenting of the duodenum or doing a bypass gastrojejunostomy, whereby the duodenal obstruction is bypassed with the gastrojejunostomy. Okay, one of the most common operation done for curative pancreatic cancer is called Whipple's procedure, which is actually a pancreatoduodenectomy. Okay, it consists of three resections. Okay, the duodenum and antrum here, duodenum and antrum, the common hepatic duct and the gallbladder, and the third is the resection of the pancreatic head. So this is known as the triple resection. And after resecting, there's a triple bypass to reconstruct this operation procedure. Okay, and this consists of first a choledochojejunostomy. Okay, common hepatic duct is joined to the jejunum. Secondly, a pancreaticojejunostomy, where the pancreas is joined to the resected part of the pancreas. And the third one is your gastrojejunostomy, stomach to jejunum. So it is before is the patient resection and after is your anastomosis. So it is a triple resection and triple bypass. Okay, in the pylorus preserving pancreatoduodenectomy or PPPD, the triple resection is still there. But instead of removing the whole stomach, the antrum and the pylorus are left behind. Therefore, the pyloric sphincter is preserved so as to prevent the reflux of duodenogastric reflux. Okay, the triple bypass is also preserved. Okay, the first one here is the choledochojejunostomy. Second one is the pancreatojejunostomy. And the third one, instead of the gastrojejunostomy, what is done is a duodenojejunostomy. This is to prevent the reflux of duodenal contents into the stomach because the pyloric sphincter is preserved. So the main difference is the gastrojejunostomy is replaced with a duodenojejunostomy to reduce the incidence of reflux. Okay, now we come to the non-resectable pancreatic cancers, where only palliation is possible. The most commonly used palliative technique is stenting of the either the bile ducts or the duodenum, whichever is obstructed by the tumor. Okay, in the first case, which is more common, is the obstruction of the bile duct by a growth in the head of the pancreas here. Okay, so there are two ways of stenting. One is known as the PTC, or the percutaneous transhepatic cholangiographic method, where a percutaneously catheter or tube, fine tube, is inserted into the ducts, dilated intrahepatic ducts and the common bile duct, and a stent is inserted through this tube where it passes and placed in the bile ducts. The second one is known as the endoscopic stenting, where the patient is done, ERCP is done, where a scope is passed, and this scope is used to insert stent into the lower end of the common bile duct. Okay, this is known as the endoscopic stenting. So both of these is the biliary stenting. Now, in case the duodenum is obstructed by the tumor and the patient develops obstructive symptoms, gastric outlet obstruction, then again you use an endoscope, the OGDS this time, to insert the stent in the narrowed segment of the duodenum. And then this will be left there. And the good thing about these new stents is that these stents are expandable. Thereby, once it's placed, it expands to dilate the duodenum or the bile duct wherever it is located. So there are three types: PTC, endoscopic ERCP stenting, or endoscopic OGDS stenting. Stent these days are very advanced. They are usually made of plastic, metal, or nowadays is made of mesh. And the good thing about this mesh is, as I said, is expandable. If it is left in place, it absorbs the tissue fluids and it expands to widen the lumen.
Okay, next, we come to the surgical procedures for palliative resection of pancreatic tumor. Okay. Okay, again, you have bile duct obstruction and duodenal or pyloric obstruction. Okay, two scenarios. For bile duct obstruction, you can either do a gastrojejunostomy, okay, cholecystojejunostomy, or a choledochojejunostomy. Here you attach the gallbladder to a loop of jejunum in cholecystojejunostomy, and in this choledochojejunostomy, the bile duct is connected to your loop of duodenum. Okay, thereby bypassing the bile duct. In duodenal or pyloric obstruction, you have got a tumor here which causes duodenal or pyloric obstruction. Therefore, the palliative surgery is gastrojejunostomy.